The technology is theoretically available for any tumor, as long as we can identify what we'll call a Trojan horse or delivery mechanism that will allow to bring the ionizing radiation close to the tumor while sparing normal tissues. And what you will hear today is that Iomab-B is a way of delivering radiation through a monoclonal antibody against CD45, which is expressed in leukemic cells, together with a radionuclide, iodine-131. So essentially, it's stuck together, and now you're delivering very high doses of radiation to the tumor without delivering those high doses of radiation to normal tissues.
Potentially arguing that you're getting 50% of the patients to survive, so which is really very, very impressive.
So what this Iomab-B has allowed us to do is, one, it's very well tolerated. I mean, they're really the mortality. I mean, you can't cure somebody who dies from your treatment. That's kind of like the paradigm. So to be able to cure them, you have to be able to deliver the treatment and actually have them tolerate the treatment well. So the 20% one-year mortality is actually extremely good. It's half of what one would expect with a traditional ablative regimen. Everybody engrafts, so the cells can take adequately. And it's a relatively well-tolerated procedure. So there is little hematologic toxicity. So it's not that people are staying in the hospital for weeks and weeks on end. So it is also a economically feasible procedure instead of, because if you have any treatment that you're keeping patients in the hospital for 50 days, it becomes very difficult to support for transplant centers. They just simply don't have the capacity. This, however, fits right in a niche where you can now provide life-saving treatment, an unmet medical need for patients over the age of 50 who have really no other curative approach. But we believe that the results are so good that at 6 months, which is the primary endpoint that the agency decided was important to make a difference, the CR rate is going to be significantly higher for the people who got the experimental arm, the Iomab-B and the transplant, versus those who got the chemotherapy, followed by, and I can tell you, in that control arm, most people who are going to get a complete remission are going to go to transplant, because that book has already been written. With chemotherapy alone, the CR rate at a year is less than 10%. Those remissions are very short.
And I think the 6-month time point is actually an important one because, again, if you look at this survival curve, most of the relapses that occurred after an Iomab-B containing conditioning regimen happened in that 6-month time period. So that really does seem to be an appropriate endpoint for the study. And frankly, I like the study simply because it is real world.
Correct.
It's allowing you to pick the chemotherapy that you believe best and then do what you would do. If that person responds, take them to transplant.